Hello everyone, I'm Mail Krishnam, Director of Cardiovascular and Thoracic Imaging at University of California, Irvine. My topic is chest CT and CTA, when and how to reduce radiation dose to patients. I have no disclosures. Next slide. Objectives of today's lecture are to review basics of radiation dose determination and calculation, discuss dose reduction strategies on CT and CTA chest, review CT protocols for common thoracic diseases, and discuss established indications for MRA and MRI in patients with thoracic pathology. I want to briefly touch on radiation dose determination, especially CTDI wall, DLP, and effective dose, specific to chest. There's a dose page displayed here on a patient who undergone step and shoot cardiac CT. In CTDI wall and DLP, these are best descriptors we have right now. However, these are based on phantom measurements. CTDI wall is volume computed tomography dose index, and it takes all parameters including pitch and rotations, but it does not include the scan length. It is displayed on the dose chart as you see above after the study as milligray. It is easily available for comparison of dose in a patient with different CT protocols, can be used to compare different CT platforms for a specific CT protocol. Next slide. Dose length product is DLP, is a measure of total radiation exposure for the whole series of images and is proportional to the scan length. And effective dose is measured in millisieverts, and it describes the non-uniform impact that radiation has on body parts of the patient exposed during imaging. In order to calculate effective dose, we have to multiply the DLP by a conversion factor, and the number for chest is 0.014. And for example, if DLP of a study is 400, and then the effective dose is 400 times 0.014, which is 5.6 millisieverts. On dose reduction strategies, I'm going to start with the scan length. We have to keep the scan length as appropriate as required for the clinical indication. It is very basic dose reduction strategy. You don't need any additional software for this, and anybody can do it, but we have to train the technologist to keep it as appropriate as possible. The scan length is directly proportional to the radiation exposure, and for CT chest we go from the lower neck to the upper abdomen. To choose the upper abdomen without going too much into the abdomen, we try to use like 2 to 3 centimeters below the lowermost costophrenic angle. By using appropriate scan length, one can save like 10 to 15% dose to patients undergoing CT study. Next slide. Tube current dose modulation is available for us to reduce the dose to the patient. It helps to adjust MAS to the size and density of the body part during scanning. There is a 20 to 40% reduction in dose to patients. However, centers do forget to switch on this function on their scanners, and it is important for a radiologist to check the images for varying MAS on the study. On the right, the top image taken at the level of the shoulder shows an MAS of 293 in a patient with CTA with dissection. The bottom image, which is taken at the mid-level, shows an MAS of 245. So I know the MAS has been switched on for this study and it is working. Another example here, CTA chest, again mid-level at the level of main PA showing 233, and Descending aorta at the level of the left atrium, the MAS is 209. Next slide. I'm going to talk about 100 kV tube voltage for CT chest applications. This is specifically used for CT angiograms, and especially if the patient is less than 30 kilograms of BMI or weight less than 90 kilograms or thin patients. There is 30% reduction in radiation dose compared to 120 kV technique. However, with 100 kV there is 20% increased noise on the images, but images are generally diagnostic. There is increased contrast attenuation on arteries and cardiac chambers, and usually the Hounsfield unit is more than 400. These are sample images of a patient with dissection of the aorta, and we used a 100 kV technique as you see here, and a Hounsfield unit is greater than 400. Average is 412 on the top image, and the bottom image shows 401.6 Hounsfield unit. Next slide. Coming to scan modes, we have volumetric scans which are routinely performed for CT chest. However, we have axial scans with intersection gaps which can be used for diffuse lung disease, especially in interstitial lung disease patients, to assess the expiratory and prone images. There's a dose page on your right showing a volumetric inspiratory scan of DLP 393, whereas the axial expiratory and axial prone inspiratory scans showing DLP much lower than the volumetric scans. Axial step and shoot technique can be used to assess aorta and coronary arteries, which can result in lower dose compared to a retrospective gated CTA. Next slide. Iterative reconstruction is very topical now, and all facilities should try to have this software on their scanners. It helps to reduce the image noise. Thus, we can use a low kV and low MAS technique to acquire the images. There is no compromise in the spatial resolution on this software application. There is a sample case on this slide showing nicely opacified aorta and pulmonary arteries with a very low dose technique utilizing 100 kV and iterative reconstruction, resulting in DLP of 142. Okay, jumping to protocols. Do we need with and without a CT chest? Answer is no. We should not do routinely double scans, and technologists should screen orders to avoid these double scans, and it is rarely performed, especially to identify calcification and or degree of enhancement of a nodular mass. However, non-contrast scans are important in patients undergoing CTA chest for aortic dissection to assess for intramural hematoma. Next slide. Common indications for high-resolution chest CT are interstitial lung disease, tracheobronchial stenosis, tracheobronchial malacia, lung transplant, bronchiectasis, and COPD. We routinely perform volumetric inspiratory scan, which gives higher dose than axial scan. However, we use axial scans for expiratory air trapping and for prone images. Prone images are performed from carina to diaphragm. Prone images would help to differentiate early fibrosis from simple atelectasis. However, on the follow-up studies with established pulmonary fibrosis, we don't need to routinely perform a prone scan. So on our right, there are two images. One on the left side is a supine volumetric scan showing ground glass opacities in the lung bases. On the right is a prone image, low dose prone image performed with axial mode showing evidence of fibrosis in the lung bases. Common indications for high-resolution chest CT are interstitial lung disease, tracheobronchial stenosis, tracheobronchial malacia, lung transplant, bronchiectasis, and COPD. We perform a volumetric inspiratory scan and low-dose expiratory and prone scans with axial/sequential mode. For interstitial lung disease, especially for follow-up scans, once there is an established fibrosis, we don't need to again perform an axial prone and axial expiratory scans. On our right, a couple of images of a patient with non-specific interstitial pulmonary fibrosis. On the left is a supine volumetric inspiratory scan image showing some ground glass opacification in both lung bases. On the right, same patient on prone position showing persistence of that reticulation suggesting early interstitial pulmonary fibrosis. Same patient's dose page shown below the images. If you see the DLP for volumetric inspiratory scan is 393 and axial scans are much lower, 55 for expiratory and 43 DLP for a prone inspiratory scan. Next slide. We do come across sometimes clinician wanting both high resolution chest CT and to assess CT angiogram for pulmonary emboli because patients presenting with some shortness of breath and decreased DLCO and raised D-dimer. In this situation, we should not do two separate scans like pre-contrast high-resolution chest CT protocol and then a CT angiopulmonary emboli protocol. We should perform rather supine volumetric inspiratory CTA, and then if patients able to tolerate, we can do an axial prone from carina through diaphragm and expiratory low dose axial scan to assess for any air trapping. Next slide. For tracheobronchial stenosis, we need to perform a volumetric inspiratory scan. However, on the expiratory scan, we don't need a volumetric. We can just perform a low dose axial scan. We don't need prone scan on these patients. And the images on the right shows the fixed stenosis. Top is inspiratory and bottom is low dose axial scan showing some air trapping too. Next slide. Different patient with the tracheobronchial stenosis, post-intubation stenosis of the trachea, and these 3D images are performed on supine volumetric inspiratory scan. Next slide. For tracheomalacia, we need volumetric inspiratory and expiratory scans. It may result in more dose, but one cannot miss tracheomalacia. Images on the right. Top one is an inspiratory scan, membrane is okay, whereas the bottom one is an volumetric expiratory scan showing excessive collapse of the membrane with air trapping. Next slide. Pulmonary nodules. One of the reasons for doing multiple CT scans on a patient. I'd like to show some characteristics of pulmonary nodules that do not need further follow-up scans. A high-density pulmonary nodule without any demonstrable calcification do not need a follow-up scan. calcified pulmonary nodules, of course, then peripheral triangular nodules or intrapulmonary lymph nodes, they do not need further follow-up. Peripheral irregular subpleural nodules or pleural tetherings, as you see on this image on our right. Nodules with internal fat density and micronodules even up to 5 mm do not need further follow-up. If your center is performing low-dose lung cancer screening protocols, you should make sure the MAS is on the lower range, and then also the effective dose of those studies should not be greater than 1 to 3 millisieverts. Next slide. Coming to CT pulmonary angiogram, the scan length for this should be kept as appropriate as possible. We should not have too much of the abdomen on the studies, and a good principle could be to keep the scan length at the level of the lowermost costophrenic angle or 2 cm below the lowermost costophrenic angle. You don't need non-contrast CT for this indication. We should perform only arterial scan, and usually we perform with 120 kV, but nowadays we can try 100 kV technique. And we should make sure that other dose reduction strategies such as tube current modulation, then iterative reconstruction software are available for this study. Next slide. This is a sample case of CT pulmonary angiogram performed on our ER scanner Philips 256 with all dose reduction strategies including 100 kV technique, dose modulation, then iterative reconstruction, and if you could see the DLP is only 186 and we didn't perform a non-con on this patient. Next slide. For CTA of thoracic aorta, we usually perform arterial phase scan to rule out aneurysm and dissection, but if the dissection is acute onset, and we perform non-con scans as well in addition to the arterial phase scan so that we can evaluate for intramural hematoma. However, for follow-up scans on patients with a dissection, we can avoid non-contrast scan unless there is any intervention. We should routinely perform 100 kV technique on these studies unless the patient has a large body habitus, and we should use other dose reduction strategies including tube current modulation and iterative reconstruction. Images on the right demonstrate 100 kV technique CT angiogram of thoracic aorta. Next slide. For status post aortic repair of thoracic aorta, we need a non-con and an arterial phase at the beginning, and potentially we can avoid the non-con portion on the follow-up studies as long as there has been no intervention on that patient. Images at the bottom demonstrate non-con scan on a patient, immediate follow-up on a patient with ascending aortic repair with an elephant trunk procedure, and you can see on the arterial phase scan on the right there are some high densities at the mid-level, and one could interpret this as a contrast extravasation, but the non-con image helps to identify these are nothing but post-surgical material. Next slide. For status post aortic stent graft repair, we need at the beginning post-operative period or a first follow-up scan, a non-con arterial phase, and then a delayed phase can be used, which can be limited to the stent, and some centers may not use the delayed scan. However, on the follow-up study after the initial CT following this stent placement, one can potentially avoid the non-con and delayed phase scans. However, if the excluded sac expands on arterial phase scan, then we should recommend a delayed scan to identify for any small type 2 delayed endoleak. Next slide. In double rule out CTA of chest, we are trying to rule out pulmonary emboli and aortic dissection. And if the question is more towards dissection, we should perform non-con, otherwise we don't need. And we don't need a non-gated study, and we should make sure that ROI is placed on the ascending aorta. The image demonstrates 100 kV technique double rule out CTA, and given the 100 kV technique, the average attenuation is usually greater than 500 or 400 Hz per unit, and on this patient, on the pulmonary arteries, the average Hz per unit is 510. Next slide. In triple rule out, we are trying to exclude pulmonary emboli, aortic dissection, and coronary artery occlusion or disease, and it's a gated study, so more dose to the patients. In order to achieve low dose, we need to do a prospective study and have a heart rate of less than 65, and if the BMI is less than 30, we should do 100 kV technique, and if we have iterative reconstructions, that would help to reduce the dose. Otherwise, the dose is going to be greater than 10 millisieverts, and you can see this patient with a triple rule out. Images are nicely shown, and aorta, pulmonary artery, and these coronary arteries, and everything is negative, and patient can go home on the same day. However, the dose may be slightly more compared to the other CTA angio chest. Next slide. Rarely you may get CT venograms, and it is important your text should understand the protocol for this, so that we don't want a repeat studies, as well as not like a triple phase scans. Here we scan from lower neck to the lower chest. We don't need an entire chest, because the idea is to cover the SVC and the right atrium, and also the brachiocephalic veins, subclavian veins, and lower jugular veins. And we give a contrast of 120 to 140 ml of contrast at an injection rate of 2 to 2.5 ml per second, and do only one scan at 120-second delay. And if you see the dose page for this patient, at the bottom we did only one scan, and nicely shows the brachiocephalic veins, then SVC, and you can also see some thrombotic changes in the left subclavian vein. Next slide. We should try to include MRI and MRA chest as an alternative to CT in order to reduce the dose to the patients for certain indications, especially for when it comes to MRA. We can assess aortic aneurysm, acute aortic syndrome, pulmonary arteries, pulmonary AVMs, PAPVR, partial anomalous pulmonary venous drainage, thoracic venous occlusion, and of course vasculitis. MRI chest can play a role in assessment of mediastinal mass, thymoma, and chest wall tumor. The top image on the right is a patient with a Marfan's, and a very young patient, didn't want to have a CT, and we did MRA showing nice aortic root aneurysm. Bottom images from a middle-aged male showing aneurysm of ascending aorta and infrarenal abdominal aorta, and he didn't want to have a CT, and MRA was performed, and very diagnostic images. Next slide. MRA can be performed to assess pulmonary emboli as well. However, I would not recommend at the acute setting, and however, if the CT is not a diagnostic, we should do MRA instead of repeating the CT. This patient with breathlessness who had a cardiac MR and noted to have incidental non-occlusive filling defects in the pulmonary arteries, and was treated, and subsequently he didn't want to have a CT. Instead, he opted for MRA, and we did a very high resolution MRA which demonstrate no evidence of pulmonary emboli. Next slide. So in summary, Radiologists and technologists should understand various dose reduction strategies on CT and CTA chest, including some basic methods such as scan length. Tube current modulation should be switched on and be utilized on all scans. 100 kV technique can be used to reduce radiation dose on CTA. Iterative reconstruction software should be available on all scanners to reduce dose to patients. CT protocols should be tailored to individual patients and clinical indications. Dose chart, this is very important, should be easily available for reference, and it should be revisited to optimize radiation dose and CT protocols. And finally, MRA should be considered as an alternative imaging modality, especially in stable patients with thoracic vascular diseases. Next slide. These are my references, and thank you for your kind attention.